The hip joint. In this video, we will cover the type and articular surfaces of the hip joint, the stabilizing factors and ligaments, blood and nerve supply, the movements of the hip joint, clinical anatomy and common conditions. Let's begin. The hip joint is a ball and socket type of joint and synovial variety. Articular surfaces. The head of the femur articulates with the acetabulum of the hip bone to form the hip joint. The head of the femur forms more than half a sphere and is covered with hyaline cartilage, except at the fovea capitis. The acetabulum presents a horseshoe-shaped lunate articular surface, an acetabular notch, and an acetabular fossa. The lunate surface is covered with hyaline cartilage. The stability or strength of this joint depends on the depth of the acetabulum and the narrowing of its mouth by the acetabular labrum. Tension and strength of ligaments. The strength of the surrounding muscles. The length and obliquity of the neck of the femur. The atmospheric pressure. Ligaments. The fibrous capsule or capsular ligament. The iliofemoral ligament. The pubofemoral ligament. The ischiofemoral ligament. The ligament of the head of the femur. The acetabular labrum. The transverse acetabular ligament. The fibrous capsule. The fibrous capsule is attached on the hip bone to the acetabular labrum, including the transverse acetabular ligament, and to bone above and behind the acetabulum. Anterosuperiorly, the capsule is thick and firmly attached. This part is subjected to maximum tension in the standing posture. Postero-inferiorly, the capsule is thin and loosely attached to bone. The capsule is made up of two types of fibers. The outer fibers are longitudinal and the inner are circular, called as zona orbicularis. The iliofemoral ligament, or inverted Y-shaped ligament of Bigelow, the iliofemoral ligament lies anteriorly. It is one of the strongest ligaments in the body. Its apex is attached to the lower half of the anterior inferior iliac spine, and the base to the intertrochanteric line. The pubofemoral ligament supports the joint anteromedially. It is also triangular in shape. Superiorly, it is attached to the iliopubic eminence, the obturator crest, and the obturator membrane. And inferiorly, it merges with the antero-inferior part of the capsule and with the lower band of the iliofemoral ligament. The ischiofemoral ligament is comparatively weak. It covers the joint posteriorly. Its fibers are twisted and extend from the ischium to the acetabulum. The fibers of the ligament form the zona orbicularis. Some of them are attached to the greater trochanter. The ligament of the head of the femur. It is also called as round ligament or ligamentum teres. It's a flat and triangular ligament. The apex is attached to the fovea capitis and the base to the transverse ligament and the margins of the acetabular notch. It may be very thin or even absent. The acetabular labrum is a fibrocartilaginous rim which is attached to the margins of the acetabulum. It narrows the mouth of the acetabulum. This helps in holding the head of the femur in position. The transverse ligament of the acetabulum is a part of the acetabular labrum, which bridges the acetabular notch. The notch is thus converted into a foramen, which transmits acetabular vessels and nerves to the joint. Blood supply. The hip joint is supplied by the obturator artery. 2 circumflex femoral, which are lateral and medial, and 2 gluteal arteries, which are superior, and inferior gluteal arteries. Nerve supply. The hip joint is supplied by the femoral nerve. Through the nerve to the rectus femoris, the anterior division of the obturator nerve, and the superior gluteal nerve. Movements. Flexion occur around a transverse axis, and the range of movement is 0 to 120 degrees. Extension occur around a transverse axis, and the range of movement is 0 to 120 degrees. Adduction occur around an anteroposterior axis, and the range of movement is 0 to 120 degrees. Abduction also occur around an anteroposterior axis, and the range of movement is 0 to 120 degrees. Medial rotation occur around a vertical axis, and the range of movement is 0 to 120 degrees. And lateral rotation also occur around a vertical axis, and the range of movement is 0 to 120 degrees. Clinical anatomy. The region of the hip joint is commonly affected by disease or injury. Some of these are briefly introduced below. Congenital dislocation is more common in the hip than in any other joint of the body. The head of the femur slips upwards onto the gluteal surface of the ilium because the upper margin of the acetabulum is developmentally deficient. This causes lurching gait, and Trendelenburg's test is positive. Coxa vara is a condition in which the neck shaft angle is reduced from the normal angle of about 150 degrees in a child and 127 degrees in an adult. Osteoarthritis is a disease of old age, characterized by growth of osteophytes at the articular ends, which make movements limited and painful. Injuries. Dislocation of the hip may be posterior, more common, anterior, less common, or central, rare. Fracture of the neck of the femur may be subcapital, near the head, cervical in the middle, or basal near the trochanters. Trochanteric fracture may be intertrochanteric that is, between the trochanters. Per trochanteric, that is, along the trochanters. Or subtrochanteric, that is, below the trochanters. These fractures occur in strong adult subjects and are produced by severe, violent injuries. Bryant's triangle. Patient lies supine, and 3 lines are drawn on both sides. First line from the anterior superior iliac spine, vertically down, to the second line, horizontally from the tip of the greater trochanter to join the first line at right angles. Third line from the anterior superior iliac spine to the tip of the greater trochanter. Diminution in the length of the second, horizontal line denotes upwards displacement of the greater trochanter. This wraps up the hip joint, a key topic for both exams and clinical practice. See you in the next video.